I'll be talking about screening tests for HIV-associated neurocognitive disorders. And you might be wondering, who is this person on this slide and why on earth have I decided to put him on my first slide? This is Marcus Tullius Cicero, the great orator of ancient Rome from the 1st century BC. And the reason he's on my first slide is this location, the Villa Tusculana, is actually built on the ancient home of Cicero. And supposedly there are ruins here at the villa that one can visit of his ancient home. And I hope we can all be inspired by his great oratory skills as we proceed with the talks of today. Screening tests are essential for making a diagnosis of dementia when one is dealing with limited resources. And brief instruments have been developed for dementia syndromes such as Alzheimer's disease by Marshall Folstein with the Mini Mental Status Exam, or MMSE. Now, this screening test was designed to screen for a cortical dementia syndrome, which has a different cognitive profile from what we see with HIV-associated neurocognitive disorders, also known as HAND. HAND has more of a subcortical presentation, so it may have greater impairment in psychomotor, motor performance, and less impaired recognition memory compared to a cortical dementia syndrome such as Alzheimer's. As a result, Chris Power and Ola Selmas in the early 1990s developed a screening test instrument specifically for HIV dementia, and that was known as the HIV Dementia Scale, or HDS. It has 4 components. The first component is 4-word memory recall, where you ask a patient to repeat and remember 4 words. Dog, hat, green, and peach were the initial words used. Then there's a test of attention, the anti-saccadic eye movement errors test, where you basically move your finger on one side and you ask the patient to look in the direction opposite to where your moving finger is. You repeat this 20 times and record the number of errors made over those 20 trials. Then there's a test of psychomotor speed, where you ask a patient to write the 26-letter English alphabet across the page as quickly as possible, counting the number of seconds it takes to do that. And finally, there's a test of time construction, where you ask a patient to copy a 3-dimensional cube as quickly as possible. Finally, you ask the patient to recall the 4 words that were given previously. Each of these 4 components is scaled from 0 to 4 points, 4 being normal performance. So the entire HIV dementia scale ranges from 0 to 16 points, 16 being normal performance. And it was found that a score of 10 or less was indicative of possible HIV dementia. When this was first looked at in the early 1990s, again, this is prior to the introduction of CART, combination antiretroviral therapies, so the syndromes of dementia were much more impaired at that time than what we see currently. But in the early 1990s, the HIV dementia scale had a sensitivity of 80% and a specificity of 91%. And the diagnostic efficiency for diagnosing dementia for the HDS was 84%. And this is similar to the diagnostic efficiency of the groove pegboard test, which is shown in the upper right. This is a neuropsychological test where you ask a patient to insert pegs into a pegboard as quickly as possible. And each peg has a groove on it, and the board has that groove at a different orientation to one another. So it's a test of both motor speed and psychomotor speed performance. So with the groove pegboard test, you had an efficiency of diagnosing dementia of 85%, similar to the HIV dementia scale. In contrast, with the Mini Mental Status Exam, it had a diagnostic efficiency of only 72%. Now, the HIV dementia scale has been used in resource-limited countries. For instance, in a study in South Africa done a few years ago, the HDS identified 17% of HIV-positive individuals with HAND compared to only 2% for the Mini Mental Status Exam. So it does seem to do better than the Mini Mental. However, in another recent study, the HIV dementia scale was not as accurate for detecting HIV dementia in card experienced patients compared to a full neuropsychological test battery using a summary measure, the NPZ-8. In addition, the HIV dementia scale includes some subtests such as the anti-saccades test and the alphabet writing and cube copying tests that may be difficult to administer by non-neurologists or may be difficult for individuals with a non-Western educational background. So as a result, about 8 years ago, we developed some modifications to this for a screening test that could be used in the international setting. And this is known as the International HIV Dementia Scale. It has 3 components. It retains the 4-word memory recall. In this case, we ask the patient to remember the words dog, hat, bean, and red, said about 1 per second, and then ask them to remember those words in a few minutes. Then we have replaced the anti-saccade errors test and the alphabet writing and cube copy with simple tests of motor and psychomotor speed. So the motor speed test is simply tapping the first 2 fingers of the non-dominant hand as widely and as quickly as possible over the course of 5 seconds, counting the number of taps performed within that interval. The psychomotor speed test is something where we ask the patient, again with a non-dominant hand, to make a fist, then a flat hand, then a perpendicular hand, to have them repeat that sequence correctly twice for practice, and then have them repeat it as quickly as possible over a 10-second period, counting the number of correct sequences performed within 10 seconds. Finally, we ask the patient again to recall the 4 words that they had repeated earlier, assigning a full point if they recall the word spontaneously, and a half point if they recall the word after a category prompting, such as piece of clothing for hat or color for red. So this is a scale which ranges from 0 to 12 points, 12 being normal performance. And in an initial study that we did in the Northeast AIDS dementia cohort in the United States, we found that patients without dementia typically scored greater than 10 points on this International HIV Dementia Scale. In contrast, patients with mild dementia and Memorial Sloan Kettering's dementia severity rating of 1 typically scored 9.3 on the International HIV Dementia Scale, and patients with moderate stage dementia, MSK stage of 2, had a mean score of 8.6 on the IHDS. We also found that performance on the IHDS correlated quite well with the performance on the groove pegboard with the non-dominant hand. However, as you can see, it does not require any special instrumentation such as a pegboard to administer, so it can easily be given by non-neurologists in an ambulatory setting. We were then interested in applying the International HIV Dementia Scale to a resource-limited country, and at the same time, we were collaborating with Nolene Nakasuja, who will be talking to you later today, in a study looking at the frequency of HIV dementia among ambulatory HIV-positive individuals presenting to an infectious disease clinic at the Infectious Disease Institute at Makerere University in Kampala, Uganda. So we were recruiting 81 HIV-positive individuals into this study. They received detailed demographic, neuropsychological, neurological, and functional assessments. We excluded anyone that had a CNS opportunistic infection. And we also recruited 100 HIV-negative individuals in order to get age and education matched normative data for the neuropsychological tests of our battery. And that battery is listed here. It included tests of motor speed, such as the groove pegboard test and time gait, tests of memory, such as the World Health Organization UCLA Auditory Verbal Learning Test, which is a list learning test that includes words that are common across cultures, such as modes of transportation or parts of the human body. It includes tests of attention and executive functioning, such as the digit span and color trails, and tests of psychomotor speed, such as the symbol digit modalities test and color trails part 1. So our seropositive patients were relatively well matched to our seronegative patients, although the seropositive subjects were slightly older and had more women compared to our seronegatives. And that reflects the fact that HIV infection in Africa is often seen in women, much more so than what we see here in the US. And our seropositive patients had greater functional impairment as measured by the Karnofsky Functional Performance Scale. The mean CD4 count of this cohort was 217, so relatively low patients with advanced immunosuppression. We found that 31% of the patients in this cohort met criteria for HIV dementia based on our full neuropsychological testing and functional assessments. And an additional 46% of our subjects had mild neurocognitive problems, consistent with an MSK stage of 0.5. And again, we found that the International HIV Dementia Scale correlated quite well with the total MSK HIV dementia rating, so that patients without a diagnosis of dementia, MSK stage 0 and 0.5, typically had an IHDS total score that was greater than 10, whereas patients with dementia, MSK stage 1, had a mean IHDS total score of 8.9. We did an ROC curve analysis looking at cutoffs that could be used. And using a cutoff of less than or equal to 10 points for the International HIV Dementia Scale total score, it provided a sensitivity for diagnosing HIV dementia of 80%, so very few false negatives. However, the specificity was 55%, so there were significant false positives, suggesting that this score might be useful for establishing a diagnosis of dementia only if you confirmed it with more detailed neuropsychological testing. Now, if you were in a clinical situation where you did not have neuropsychological testing available to you, and all you had to do was to rely on the International HIV Dementia Scale, then we might suggest a cutoff of less than or equal to 9.5, which provided a specificity of 77%, so very few false positives, with a modest decrease in sensitivity to about 60%. So the cutoff that you use for these screening tests is dependent on the clinical setting that you're in. We also looked at risk factors for a diagnosis of dementia in this Uganda study, and we found that low performance on the International HIV Dementia Scale, as well as simply having memory complaints subjectively. In other words, are you having problems with your memory? As well as low education, were all associated with an increased risk for diagnosing dementia. Now, the International HIV Dementia Scale has now been used in multiple countries, in Africa, in Asia, and South America. And this slide just summarizes some of that use. For instance, in Cameroon, in a fairly large study of over 400 HIV positive and HIV negative patients, the International HIV Dementia Scale, using a cutoff of less than or equal to 10, identified 21% of HIV positive patients with dementia compared to only 2.5% of HIV negative patients. In a study in South Africa, among HIV positive patients with low CD4 counts, using the same cutoff, it had a sensitivity of 88% and a specificity of 50%. However, in a more recent study by John Joska, who will be here later today talking as well, among HIV positive patients, the IHDS had greater impairment among these patients compared to HIV negative controls. However, when confirmed with a detailed neuropsychological test battery using the same cutoff, the sensitivity was not as good as what we had seen in previous studies, only 45%, although the specificity was better at 79%. In another study in India, also with subtype C HIV infection, again, the IHDS scored fairly well, identifying 35% of patients with cognitive impairment compared to 15% among seronegatives. So what are some of the factors impacting the utility of a screening test like the International HIV Dementia Scale? Education seems to be important. In a recent study among HIV positive and HIV negative individuals with early stage infection in India, it was education rather than HIV status that seemed to be associated with poor performance on the screening test. Stage of infection is also important. In a study done in Ethiopia, it was found that there was no difference among HIV positive and HIV negative patients on their International HIV Dementia Scale score. However, interestingly, none of the neuropsychological tests used showed any difference between the seropositive and seronegative studies in this study. Part of the reason may be that this was a community-based study in which individuals were recruited and the examiners were blinded to the serostatus of the patient. Another possibility is that the seropositive patients in this study had less severe immunosuppression than what was seen in previous studies looking at the screening test. However, in another study performed in Argentina, again, the International HIV Dementia Scale performed fairly well with a mean score of 10.9 among HIV positive patients. But again, these were patients that had relatively preserved immunity, not patients with advanced immunosuppression. So it seems like stage of infection is important and that this screening test is particularly useful in patients with more advanced immunosuppression. Hepatitis C co-infection may also be important. There was a recent presentation at this year's CROI meeting, the Conference on Retroviruses and Opportunistic Infections, that suggested among HIV asymptomatic patients on combination antiretroviral therapy in the United Kingdom, poor performance was actually more associated with hepatitis C co-infection with the IHDS. And stage of hand impairment is also important. This screening test was designed to make a diagnosis of HIV dementia. It was not designed to diagnose some of the milder forms of cognitive impairment that are associated with HAND, such as asymptomatic neurocognitive impairment or mild neurocognitive disorder. Now, other screening tests have also been used to try to diagnose HAND. At this year's CROI meeting again, two of these tests were the Montreal Cognitive Assessment, or MoCA, which is a 30-item screen for age-associated mild cognitive impairment among the elderly. So these are seronegative people that it was designed for. Using a threshold of less than or equal to 25, among HIV-positive individuals, the MoCA had a sensitivity for diagnosing HAND of 59% and a specificity of 81%. So good specificity, average sensitivity. The 88, which is an 8-item interview comparing current and previous functioning due to cognitive impairment, again had a sensitivity of 62% and a specificity of 63%. So both the MoCA and the 88 did correlate with formal neuropsychological testing as measured by the NPZ-8. However, the sensitivities were lower than desired for a screening tool where you want to potentially identify anyone at risk for having the clinical syndrome. Now, in addition to screening tests that can be done in the span of 5 minutes or less, brief neuropsychological test batteries have also been developed. These take a little bit longer and may require some special instrumentation or papers to do the tests. But these have been developed, and one of these is by Ron Ellis, who will be talking later today, looking in the AIDS clinical trials group in the ALERT study and in a NARC study in which he examined over 300 HIV-positive individuals. And the tests that were used in this battery were the digit symbol test and the trail-making test, looking at parts A and B. It takes about 15 minutes to administer. And using a mean z-score of the 3 neuropsychological tests as a summary measure, and using a cutoff of negative 0.33, provided a sensitivity for diagnosing HIV dementia or HAND of 65% and a specificity of 72% with a correct classification rate of 68%. And recently, a memory test, the Hopkins Verbal Learning Test total score, has also been added to this battery to assess both psychomotor speed and memory function in the ALERT study. We've also looked at a similar brief battery of neuropsychological tests in the multi-center AIDS cohort study, a cohort of gay bisexual men, the MACs, and looking at the trail-making test, which is shown in the upper right, where you ask a patient to draw a line between letter and number, starting with the number 1, then going to A, then continuing that line to 2, to B, etc. Timing the time it takes to perform that. And then also looking at the symbol-digit modalities test shown in the lower right, where you have a series of symbols associated with numbers, and you ask the patient to put in the appropriate number for each symbol across the page. So in this study that was actually done a while back in the early 1990s, of almost 300 HIV-positive individuals, having decline defined as 2 standard deviations on one of these neuropsychological test components that was then sustained over 2 consecutive visits compared to their previous performance, was associated not only with an increased risk for a diagnosis of dementia, but also an increased mortality risk associated with them as well. So what are some of the challenges associated with using screening tests for hand? As I've already alluded to, the severity of impairment is important. These tests have been developed specifically for diagnosing HIV dementia, but they haven't been developed for diagnosing both mild neurocognitive disorder as well as dementia. Sensitivity is also an issue. There's no specific cognitive domain that's always impaired in a patient with HIV dementia. Some patients may have impairment in psychomotor speed performance, others may have impairment in executive functioning, others may have impairment in memory, but there's no specific domain that you can use in a screening test to diagnose the condition. Specificity is also an issue. Cognitive impairment with HIV is similar to impairment seen in confounding conditions, such as vascular disease, or as I already alluded to, hepatitis C co-infection. Reliability is also key. These screening tests need to be performed in the same manner with every patient, and training is absolutely essential. And validity is also important. Is the cognitive profile of hand changing with time? For example, is the profile of mild neurocognitive disorder different from that of dementia? Are we seeing greater age-related effects or more cortical deficits? And this was actually seen in a study by Bob Heaton, who will be talking next, where he compared the neuropsychological domain impairment among CART-experienced patients to those seen in the pre-CART era, and found that patients on CART seemed to have greater deficits in learning and executive functioning and less impairment in tests of speed of information processing, motor and verbal fluency performance. So in summary, screening tools can identify individuals that are at high risk for HIV dementia. These instruments need to be performed in a standardized manner for every patient. These screening test results, if at all possible, need to be validated with a gold standard of neuropsychological testing with functional assessments, as well as an evaluation for comorbid conditions. The norms for the screening tests for HIV dementia need to be improved in hard-experienced patients, in older patients, and in resource-limited countries. And in fact, the latter is now being done by Kevin Robertson in another AIDS clinical trials group study called 5170, in which the International HIV Dementia Scale is now obtaining some normative data among seronegative individuals across 10 different countries throughout the world. And screening tests for mild forms of cognitive impairment, including both asymptomatic neurocognitive impairment, or ANI, mild neurocognitive disorder, or MND, and dementia need to be developed. I'd like to thank my collaborators at Makerere University, in particular Nolene Nakasuja, who will be talking to you later today, as well as Ellie Katabira, and the support we've received through NIH. And I'd like to leave you with a quote from Cicero, the great orator, who said, "I never heard of an old man forgetting where he had buried his money. Old people remember what interests them." And in fact, maybe we should be using a simple screening test like this for our patients. Thank you.